This third talk is about what we can and cannot do to reduce our risk of heart attack and stroke. I'd like to suggest that if you haven't looked at the first two podcasts, you do so before listening to this one. The major problem is that medicine has used the onset of symptoms such as heart attack or stroke to define the presence of the disease atherosclerosis. As I have said many times in these podcasts, the disease atherosclerosis is present in 100% of us to a varying degree, and only some of us will develop symptoms. Atherosclerosis commences decades before any of the so-called risk factors occur. They can't be the cause. As I've said, this is putting the cart before the horse. These risk factors identify those of us who are more likely to develop symptoms. It doesn't identify those of us who have atherosclerosis. Some of these risk factors can exacerbate the severity of atherosclerosis, in particular smoking and high blood pressure. The risk factors that we can't do anything about are referred to as non-remedial risk factors. And the ones that we can do something about are called remedial risk factors. The risk factors that we cannot do anything about are getting old, the angle that our arteries divide at, and choosing our parents. In other words, the genes we inherit. We cannot prevent, nor do we want to prevent ourselves from getting old. The risk of heart attack and stroke increases with age, reflecting the increasing severity of atherosclerosis. Age is probably the biggest risk factor for stroke. The 10-year risk of heart attack and stroke in a perfectly healthy white male without any risk factors increases from 2.8% at the age of 50 to 13.1% at the age of 70 and 24% at the age of 79. The 10-year risk of heart attack and stroke in a 50-year-old male skyrockets to 32% if he smokes, has diabetes, high blood pressure and high cholesterol on treatment. His 30-year risk is 67%. We cannot control the angle at which our arteries divide. We know from the Korean War veteran study that the critical angle that predisposes to worsening atherosclerosis is 80 degrees. We cannot choose our parents, and by that I mean we cannot dictate what genes we inherit that may increase our risk. There are families where heart attacks and strokes occur at a very young age. There must be a genetic cause, and yet very few genes have been discovered. I suspect this relates to the fact that we are using symptoms to define the presence of atherosclerotic vascular disease, but symptoms are only the tip of the iceberg. The rest of us with atherosclerosis are invisible. When we go to a doctor, we are often asked if there is a family history of heart attack or stroke. And if we say yes, it's assumed we have inherited a bad gene. But this may not be the case. In the great majority, we have developed the same disease of atherosclerosis that has occurred in our relatives. A small number of identical twins have been shown to inherit genes that lead to arteries that are more prone to atherosclerosis. These were young, between the ages of 33 and 57, and over 3/4 of them had identical coronary arteries and identical sites where these arteries were affected by the atherosclerosis. There's a single case report of non-identical twins who had very similar coronary anatomy and sites of atherosclerosis. I wonder, but I have no proof, that perhaps heart attacks and strokes run in families because they inherit the genes that influence the way their arteries divide and therefore inherit an increased risk of developing atherosclerosis. There are a few very rare diseases where a single gene increases our risk, as it did in the Otzi Iceman. These account for a tiny proportion of cases of heart attack and stroke. In recent years, it has been suggested that we inherit an increased risk contributed to by many of our genes, the so-called polygenic risk score. The problem with the polygenic risk score is that it is derived from patients who have symptoms, not from patients who have the disease, i.e. atherosclerosis. There is a condition that affects less than 1% of us, that we inherit from our parents. It's called familial hypercholesterolemia, and the abnormality is on the 19th chromosome. You know that we have 46 chromosomes altogether. We should measure our cholesterol at a very young age if one of our parents has had a heart attack or a stroke under the age of 50. We should also measure our cholesterol if we develop these small orange bumps under our skin called xanthomata. If our cholesterol is very high, or if we have these xanthomata, we should have the genetic test for familial hypercholesterolemia. The homozygote form, which means we inherit two abnormal genes, is extremely rare. It occurs in about 3 in a million people. It causes very severe hypercholesterolemia, and this is treated very aggressively with drugs, but also washing the cholesterol out of our blood, like patients who have dialysis for kidney failure. If we have several first-degree relatives who have died either of a heart attack or stroke at a young age, a somewhat controversial suggestion is that as well as measuring our cholesterol, perhaps we should measure our coronary calcium score. A higher coronary calcium score predicts more severe atherosclerosis of the arteries to our heart. And these arteries could have a severe stenosis that may not cause symptoms and yet could cause sudden death without any warning. I would now like to discuss the things we can do something about. These include smoking, high blood pressure, obesity, physical activity and diabetes. Cholesterol was discussed in the second podcast. The irregular heartbeat, called atrial fibrillation, that increases our risk of stroke, will not be discussed in this podcast. Believe it or not, the hazard of smoking had been reported as far back as 1795 by Dr. Samuel Sommering in Germany. In the 20th century, smoking was fashionable and socially acceptable. Ronald Reagan gave his friends Chesterfield's cigarettes for Christmas. In the 1950s, smoking was shown to cause lung cancer. It took another quarter of a century to show that it caused heart attacks and strokes. Smoking, including second-hand smoke, almost doubles the risk of heart attack and stroke. And this is probably because smoking damages that inner lining of our arteries, the intima. The risk is estimated to increase by 12% for each increment of 5 cigarettes we smoke per day. High blood pressure is said to be the cause of atherosclerosis, and it certainly increases our risk of developing symptoms. But as I have said, atherosclerosis commences decades before we develop high blood pressure. The fact that atherosclerosis, with stiffening of the walls of our arteries, commences decades before the onset of high blood pressure would, to my way of thinking, suggest that high blood pressure is due to atherosclerosis and not the other way around. You can imagine our circulation is like an irrigation system. It has a pump, the heart, pipes, the arteries and veins, fluid in the pipes, blood, and fields to irrigate, i.e. our cells. The pressure inside a closed loop reflects the size of the pump, the amount of fluid in the pipes, the stiffness of those pipes, and the resistance to outflow. It can't be due to a bigger pump because our heart only enlarges after decades of poorly controlled high blood pressure. The smooth muscle cells of both large arteries and small arteries, called arterioles, constrict in response to increased pressure and dilate in response to decreased pressure. This is known as the Baylis effect. Thus, increased resistance to outflow cannot be the cause of high blood pressure. This leaves stiffness of the walls and the amount of fluid in our pipes. We have already pointed out that there is a marked increase in the amount of fluid in our arteries, i.e. the blood volume, with obesity, and this also occurs in renal failure. when this excess fluid is removed from the arteries in patients with kidney failure, during dialysis, the blood pressure falls. Logically, this leaves us with the stiffness of the walls of our arteries as the likely cause of essential hypertension. And stiffness of the walls has been documented decades before the onset of high blood pressure. When I graduated, a normal blood pressure was defined as 100 plus your age. This is no longer the case. The current recommendation is that our blood pressure should be less than 140 on 90, although in the USA they say less than 130 on 90. Numerous studies during the 20th century have shown that the lower the blood pressure, the risk of heart attacks and strokes is reduced. In the very first study of treating blood pressure, the 1967 Veterans Affairs study, they were treating people with very severe high blood pressure with diastolic levels of 105 to 124 millimetres of mercury. It needed only 143 patients and 15 months to show a whopping 83% relative risk reduction and an equally impressive 46% absolute reduction. In contrast, the 2001 Progress study of 6,105 patients with a previous TIA stroke found a 28% relative risk reduction and a 4% absolute risk reduction over 4 years. Once high blood pressure develops, it creates a vicious circle of worsening atherosclerosis. We should not accept our doctors saying our blood pressure is okay. We should ask them for the exact reading and insist on more treatment if it's not 140 on 90 or lower. Obesity is a major risk factor, and this graph says it all. If we are morbidly obese with a BMI greater than 40 kilogram per metre squared, a little less than half of us will live beyond the age of 70, compared to 77% who have a BMI of less than 25 kilogram per metre squared. And nearly 1/4 of those who are morbidly obese will not reach the age of 60. We are more likely to develop high blood pressure, high cholesterol and diabetes if we allow ourselves to become obese. There isn't a day goes by without the mention of how beneficial physical exercise is, but just how beneficial is difficult to quantify. In the 2018 Physical Activity Guidelines, they say that benefit starts immediately after we commence exercise, and even short periods of physical activity are beneficial. Everyone benefits. If exercise helps us to lose weight, that could eliminate type 2 diabetes, lower our blood pressure and cholesterol. This obviously would decrease our risk of heart attack and stroke. However, exercise reduces our risk of heart attack and stroke in the absence of weight loss. Exercise decreases our blood pressure and it decreases our resting heart rate. Both of these will result in less physical damage to our arteries. I'm a keen cyclist. I ride 120 to 150 kilometres a week. Exercise increases the levels of the chemicals that are produced in our brains called endorphins. These reduce stress and improve our mood. Eating and sex also increases our endorphin levels. Type 2 diabetes virtually disappeared in the 1871 Franco-Prussian War during the Siege of Paris. In World Wars I and II, the disappearance of diabetes was the result of severe food shortages and marked weight loss. This makes a lot of sense, doesn't it? Because type 2 diabetes is largely related to obesity. So to summarise these three talks, it is physical damage to our arteries that initiates the process of atherosclerosis, leading to progressive thickening and stiffening of the walls of our arteries and the accumulation of cholesterol beneath the inner lining of the arteries, the intima. If we elect to smoke and allow ourselves to become obese, both of these will make atherosclerosis more severe and increase our risk of developing heart attack and stroke at a younger age. If we want to reduce our risk of heart attack and stroke, we should not smoke. We should avoid gaining weight, or if we're overweight, lose weight, and we should use drugs and diet to treat our cholesterol and diabetes. If we develop high blood pressure, we should use every means to keep our blood pressure at 140 on 90 or less. If we're overweight and we can lose 10 kilograms, our systolic blood pressure will decrease by 10 millimetres of mercury, and that is a very significant decrease. Theoretically, there is a way we can virtually eliminate our risk, as happened in the 3 years after World War II in Finland and West Germany. Severe food shortages occurred at that time, and people had to survive on 1,000 to 1,200 calories per day. The result was massive weight loss. Cholesterol levels almost halved. Heart attacks and strokes disappeared. At autopsy, there was no atherosclerosis in the arteries of these individuals, nor is atherosclerosis seen in the walls of the arteries of starving prisoners of war. Everything seems so complex until it looks simple. Knowing that atherosclerosis commences when we are still in our mother's womb, and that by the age of 3, every single one of us has the beginnings of atherosclerosis that will worsen with increasing age, that the principal initiating cause of atherosclerosis is the physical damage to our arteries, present in every single one of us, then everything seems to fall in place. It can explain why strokes and heart attacks occur in children and young adults, why strokes and heart attacks occur in healthy individuals without risk factors, and it explains why strokes and heart attacks are more frequent as we get older. I also believe it provides an insight into the cause of essential hypertension or high blood pressure. There is so much more I would like to share, in particular the advice not to eat fat, which was based on the flawed research of an American physiologist, Ansel Keys. The northern tribes of Kenya and Tanzania and the Inuits of Alaska and Greenland eat virtually nothing but fat and meat, remain thin, and do not suffer heart attacks or strokes unless they move to an urban environment where they become obese. So it was not good genes that was protecting them. It was not the omega-3 fatty acids found in fish that protected them. It was the fact that they remained thin. The secret to longevity throughout the entire animal kingdom is caloric restriction. In 1933, researchers extended the life of rats by 33% by restricting their calories. The extra information I would like to share is in my book, and hopefully one day the book titled Struck Down by the Gods will be published.